on behalf of all the speakers, I'm Dr. Biju Raju, and would like to invite all of you and welcome you all to this session on innovations and innovators session called the Mind Lab.
So good evening, good afternoon all. We are having the Mind Lab session.
So we'll start the session with the innovators, the best innovators from Kerala who have been selected, and like we start with one of the biggest minds in the history of mankind, Albert Einstein. You all know about E is equal to mc square, but E is equal to mc square did not come as E is equal to mc square, but as L equal to, M equal to L by C square. And then he reshuffled after about 7 years. So it takes time for the ideas to incubate. And in 1912, he came out with the idea that E is equal to mc square, the mass energy equivalence. We hope to see something of that sort today from all these innovators here. And I invite Dr. John to start off introducing the speaker for the next talk. And I'm sure this session will ignite the spark for creativity and innovative minds who are waiting for an inspiration. And you will get the right tools to go forth with your innovative ideas. So welcome to the Mind Lab.
Thank you, sir. So Dr. Biju Raju is an innovator and a mentor for many of us. He has mentored me, and we did do-it-yourself red cam when I was doing my PG. So thank you, sir. And he has innovated and he has inspired many innovators. So we will first start with Dr. Anil Radhakrishnan. Dr. Anil Radhakrishnan, sir, he is a consultant cornea and refractive surgery and associate professor at Amrita Institute, Kochi, and medical director of the Amrita Eye Bank. And he has been practicing cornea and refractive surgery for a long time. And his areas of interest, corneal infection, dry eye. He has reported the first microvascular submandibular gland transfer, first surgeon in the state to perform big bubble DALC, DESEC, topo-guided PRK, corneal neuratization. And he is in charge of the cornea division of BIRAC, and has 12 peer-reviewed publications, 12 international presentations, and more than 100 national and local presentations. Over to you, sir.
Thank you, Biju, Prithvi, John, and all the young innovators. I'm a bit of an odd man in the group with a lot of gray hair. So our studies about bacteriophages, a novel approach to combat multi-drug resistant Pseudomonas corneal infections. This is a combined work of Amrita Biotechnology as well as the Amrita Institute of Medical Sciences. As you all know, infective keratitis is the second most common cause of vision loss, and we have anywhere close to 10 million people who are corneally blind. And among the keratitis, Pseudomonas keratitis is notorious. It has multiple mechanisms of resistance, intrinsic resistance to a lot of antibiotics, your routine antibiotics, most of them are intrinsically resistant. Then you have the extrinsic resistance. Then there is something called adaptive resistance, which comes because of the biofilm and the mucoid character and all that. So whatever it is, Pseudomonas is a bug which is dangerous, and more than 30%, and some of the studies close to 48% of the bugs are resistant to multiple antibiotics. So I think then another thing is the phages are viruses which need a host bacterium, and they're very specific to the bacteria. So I think India has some connection to the bacteriophages in that it was first described the water from Ganga and Yamuna had this bactericidal action. At that time, phages were not known to humankind. So it was reported, and it was there in the literature from 1896. So they reported that this water from these rivers have got bactericidal action. But it was Frederick de Herelle from Paris who got this bacteriophage. He's credited with the discovery of bacteriophage along with Thwart from UK. So he came all the way from Paris to India. He spent time in India. That time cholera was all around, and he gave phages to some villages, put it in the wells, put it in their food and all that, and found that the prevalence of this cholera infection was much less in these villages where it was used. Then it was very popular in Eastern Europe and even now, but it lost its prominence because of the emergence of antibiotics. So we had isolated a particular bacteriophage called AMP2. AM stands for Amrita and P for the Pseudomonas. It is from the wastewater from Kollam. As you see the structure over there, that is the genomic structure which was characterized, and that was actually given this name by the ICTV, the International Collegium for the Nomenclature of Viruses. So it is seen to be a phage against the multi-drug resistant Pseudomonas. So they had multiple types of these phages, AMP1 to 9, and they found that what in the in vitro studies what they found is that the cocktail of AMP2, 4 and 5 are the most effective. So the aim of a study was to look at the efficacy of the cocktail, this bacteriophage cocktail against multi-drug resistant Pseudomonas keratitis. So these bugs were isolated from various sources, mainly from this brackish water and all that. So this water sample was taken, put in equal amount of enrichment broth, then they have overnight culture was done, and centrifuging and then collection of the phages were done. Then bacteria were filtered out. Then there is a process of phage multiplication called this double agar overlay, and multiple methods which as ophthalmologists we don't know. And basically, finally, phage pellets or concentrated phages were made in SM buffer and stored as high titer stocks. So to produce the corneal infection model, we use the corneoscleral rim, which is abandoned cornea. So we put this agar gel on the downside, on the endothelial side. Then we made the scratches on the cornea, and then kept a Trufine on top, and which was rotated up to 300 microns, 3 rotations, and it was made water sealed by putting cyanoacrylate glue. So it was a watertight container into which the Pseudomonas condensate was put. And followed by that, this phage combination was put, and it was incubated overnight. So at the next day, it was homogenized. The resulting suspension was spotted on LB plates. So 4 pairs of corneal buttons were used. One pair contains only the Pseudomonas, and second, the control pair, the phage treated pair will have the Pseudomonas followed by the phage treatment for about 8 to 10 hours. So in that, what we found is there is a remarkable difference between the colony counts between the in the first pair. The similar story was seen in the second pair, third pair, as well as the fourth pair. The fourth pair, there is some yellow pigmentation because of the pyoverdine. So it was seen to be highly effective in killing multi-drug resistant Pseudomonas. And this is a Pseudomonas PA01 was a multi-drug species which was grown. So with the industry shying away from the investing in newer antibiotics, phage cocktail has got a real potential in the treatment of Pseudomonas keratitis. And there are certain off-label studies done in Georgia and all, in which people have traveled to Georgia and got these bacteriophage drops. But this AMP, this particular phage was prepared from India. It's a made in India phage. Thank you so much.
Thank you, Dr. Anil. That was a wonderful presentation. We'll have a discussion at the end of all the talks, which is easy to manage. Next, I call upon Dr. John Davis. He needs no introduction. He's an innovator par excellence, and he keeps moving forward with a lot of new ideas and a lot of new innovative stuff that comes from him. Let us hear from him. Over to you, Dr. John.
Thank you, Dr. Vijayaraju, sir. And I am going to present my 3D printed innovations. So, I have some financial interest because I am making some commercial devices from 3D printing. Some of my designs are open source and free. If you scan these QR codes, you can download those 3D designs. You can print those 3D designs and use it in your hospital. PGs and other people, take a photo right now, take out your smartphones. Most of the time we tell no smartphones. Now we say, take out your smartphones, take photos, these QR codes, you can download the 3D designs. Okay, I think we are going to the next slide. So the process of 3D printing starts with designing. Using CAD software, you design something and then you use a slicing software to slice it and convert it to G code, which is what the 3D printer understands. And then you send it to a 3D printer, and then there is some, after 3D printing, there is some post-processing. You will not get exactly a very good finished product. You might have to use acetone or heat or UV to finalize the product, and that product can be used either as a prototype or even as a final end product. This entire part of slicing printing, you could outsource to a 3D printing shop. If you open Google Maps and search 3D printing near me, you will find 3D printing shops. So materials, a lot of plastics, PLA, ABS, nylon, and you can even 3D print in titanium, but that requires a different 3D printer. The plastics 3D printer, that is a filament-based FDM 3D printers, start at around 15,000 rupees. Yes, not dollars, rupees. And the resin printers start at around 20,000 rupees. So very affordable. You know, somebody has a birthday and you want to give a gift, ideal gift. My birthday is coming soon. So, so there's a lot of techniques of 3D print. The ones which you need to know are the FDM and the SLA. FDM uses a spool of plastic and uses that to melt together the plastic into the design that you need. SLA resin printer uses a liquid resin which polymerizes with UV light. Much faster and much higher resolution with the resin printing that is available in all the dental labs also. So 3D printing shops, if you cannot find, go to a dental lab. They have these 3D printers. Or your engineering friend, they have these 3D printers at home. So over to the next slide about ophthalmology. Starting from cornea to retina, there is a lot of 3D printing involved. We'll get to that. And we have accessories, prostheses, implants, adapters, even for surgical planning and teaching. So 3D printing has a lot of uses. And my 3D printed innovations, I'll go through those quickly. So it's a magic device. So you can think of something and then make it come to reality. So about, yes, article on 3D printing in Kerala Journal of Ophthalmology. All of you, please publish in the Kerala Journal of Ophthalmology. It's a very nice journal, no publication charges, no financial interest. So one of them is the eye drop guide, which Dr. Ankit will be talking about soon. So I'm not going into detail about that. So I try to mentor some PGs and students into doing stuff. This is a 3D printed punctal plug and drug delivery system. I was in Ramchandra Medical College. I was teaching the MBBS students. I told them, you can do 3D printing in ophthalmology. You have, these are the various things which you can, which are already done. These are the things you can try. And they wanted to do a project. 2 MBBS students in 3rd year of MBBS ophthalmology posting came to me and said, sir, I want to do a 3D printing project. This is what we did. We sat together and planned it out. They drew the 3D printed design. They 3D printed in the dental lab. And they came to me and said, sir, we 3D printed this. So this is what is possible. You can think of an idea and make it a reality with the magic of 3D printing. Another one is a glaucoma drainage device. I wanted to start doing implant surgeries, so glaucoma drainage devices. And I wanted to get an implant so that I can practice in the wet lab. I said, why not draw the design and 3D print it? So these designs can be downloaded from these websites. So designed this, made the 3D print, implanted it in a wet lab in Gordsai. So that is for wet lab practice. You can also use it for innovating new design. Suppose you think of a new design of a glaucoma drainage valve which has a variable controller. Design it, print it, test it, design doesn't work, again, make it again, iterate, find out what works. Once it is final, you can finalize it into a proper design, right? MIGS implants, so lots of MIGS devices are there. I wanted to, get into MIGS, so drew that MIGS designs, 3D printed them, even made them in augmented reality. So this is augmented reality. You can have this in virtual space in front of you. You can pick it up in your hand, move it around. You can do this for teaching, PGs, patients, whomever. So any 3D design you can use in augmented reality as well. Then cataract surgery instruments, this is phacoprobe, IOL, dialer, chopper, IA cannula. These are various glaucoma drainage devices, RD, CTR, CTS, everything. And dehexening, of course. You can download and print, okay? Or you can put in PowerPoint. So all these 3D models flying around, the same files put in PowerPoint as a 3D model, okay? Very easy to do. And next you have the cataract surgery big model. So cataract surgery training, it's very difficult to see. So we designed a big model of cataract surgery. So this is a stained anterior capsule. This is a yellow nucleus, and behind it you can see the orange-red glow. So all these things we 3D printed in huge size, so that when you teach your residents, you can tell them, this is a nucleus piece, this is how you lift it up, this is how you chop. All those things are much more clearer when it is big. So big sized cataract surgery, 3D printed. Then of course the foldable funduscope, inspired from Dr. Biju Raju. We designed a fundus camera, but I wanted to make it more and more portable. So I made it into a foldable pocket size design. Again, drew this myself and 3D printed it, made it a reality, and patented it. So that is another thing which you can do with 3D printing. You can think of something which you want to make, you can make it, patent it, and win awards also like this. Yeah. So this is about the foldable funduscope, and I think that's it. Thank you. Hope I inspired everybody to buy their own 3D printers, start 3D printing, and these are the sites where you can design 3D things. Tinkercad.com, or you can go to Google Maps, find a place where you can 3D print. You can design 3D designs in AI, Meshi.ai. You can design 3D designs. You can just give a photo and tell it to make something, or you can give it in text also, Hyper3D.ai also. So you don't have to learn 3D printing, you don't have to buy a 3D printer, you can do it all, okay? Thank you.
Thank you, John. Thank you for the lovely presentation. We got an overview of what 3D printing actually is, and I hope it has inspired many of you. It has really inspired me to look at that aspect. Next, I call upon Dr. Sinamore, another prolific innovator. We'll hear from her what she has done in the last few years. Over to you, Doctor.
Good morning all.
Necessity is the mother of invention. When I started working in the periphery, I came across many cases of aphakia with poor cornea or iridodialysis that forced me to think about a simple technique for scleral fixation of an IOL. The materials used are a 26 gauge 1.5 inch needle and 10-0 prolene. The advantages of this technique are minimal intraocular manipulation and an exact 180-degree fixation, which gives excellent next day results. This technique won the ASCRS award in 2013.
Single haptic fixation of IOL is a faster and easier technique of scleral fixation when there is some capsular remnant. This technique utilizes the available capsular remnant to support the leading haptic. The trailing haptic is fixated to the tunnel bed. This is a traumatic subluxated cataract with 180 degrees zonular dialysis. After staining, rhexis, and controlled hydrodissection, nucleus is removed by phaco sandwich technique. Cortical wash by tangential pull. There is 180 degrees dialysis nasally. So needle is passed through the nasal end of the tunnel bed It emerges out through the cornea. Needle is cut off. Suture is retrieved and tied to the trailing haptic of IOL. IOL is positioned with leading haptic supported by the bag infratemporally. Scleral fixation of the trailing haptic to the tunnel bed is done. This is a subluxated IOL. Here the needle with proline is passed under the superior haptic and emerges out through the cornea. Needle is cut off. The suture is retrieved. As we pull out the suture, IOL is also coming up and the superior haptic is presented at the tunnel. Suture is tied to the superior haptic. The IOL is positioned back. Stability is ensured. Fixation is done after taking a bite from the tunnel bed.
This technique is minimally invasive and very useful in many situations such as aphakia, intraoperative sonnular dialysis, posterior capsular rent, subluxated cataract and subluxated IOL. This video demonstrates an instant proline snare prepared using a 3-0 proline suture and an 18-gauge cannula. To prepare the snare, the stylet of the cannula is removed, all caps are taken off, and the sharp tip of the stylet is trimmed. A short segment of 3-0 proline is used. Both ends of the suture are passed through the tip of the stylet, creating a loop at the distal end. The free ends emerging at the hub are tied together securely to provide a firm grip. With this, the proline snare is ready for use. The case shown here is a grade 3 nuclear sclerosis cataract. A 4 mm sclerocorneal tunnel incision is fashioned. Following a capsulorhexis and hydrodissection, the nucleus is gently prolapsed into the anterior chamber. Adequate viscoelastic protection is essential before introducing the snare. The prepared snare is then advanced and opened to lasso the nucleus. Once positioned, traction on the outer loop allows the snare to cleanly divide the nucleus into two halves. Each heminucleus is removed through the 4 mm tunnel using a vectus. A foldable intraocular lens is implanted into the capsular bag. In this video, the proline snare is used to divide a nuclear sclerosis grade 4 cataract. You can see that the proline snare is dividing the nucleus smoothly. The proline snare is more endothelium friendly than a metallic snare and offers greater endothelial safety than performing phaco in hard cataracts, making it a safer alternative in such situations. It is also useful when a phacoemulsification machine is unavailable or non-functional and the post-operative outcomes are comparable to phaco. Each endothelium is precious for every phaco surgeon. Here is a simple technique for effective endothelial protection during phaco. Use an anterior chamber maintainer with visco. Keep it connected to the peripheral anterior chamber. An assistant can safely push visco whenever required. This scope can be injected without taking out the probe. This is especially useful for beginner surgeons and in situations of sudden posterior capsular rent. Thank you.
Thank you very much.
So next we have Dr. Prithvi Chandrakant. He is a prolific serial innovator with more than 24 innovations, 30 articles, and most of them being innovations, 170 scientific presentations, instruction courses, so many awards, and he is also in editorial boards and everything. Young ophthalmologist to watch out for. Over to you, Dr. Prithvi.
Thank you, John sir, for the introduction. I'll be talking about do-it-yourself innovations for all ophthalmologists. So first, I have some financial interest over here. These are the products. So first I'll go with the ASP, anti-segment photography with intraocular lens. Basically this is a very simple way of taking anti-segment photo. You just need to take a black chart. Here it is a white chart, but you can take a black chart, you can reduce the reflection and cut it into a strip of 10 centimeter into 1.5 centimeter long strip. So once that is done, you'll be getting this kind of a strip. And on top of that, you have to mark the area where the intraocular lens will be placed. So this is the place where you're going to put the intraocular lens. So between that, what we'll do is we'll be putting a double-sided sticky tape. So this particular tape has two-sided stickiness, and then we'll put a puncher, paper puncher. We'll make a small hole. So once that is done, you will be putting the intraocular lens in that particular hole. So that is exactly 6 millimeter. So once you have done that, you can take the double-sided tape, the second side, you can open it, and then at this particular place, we can put the intraocular lens. So we are placing the intraocular lens over here. Around 15 to 20 diopter IOL will be placed here. And this is actually put onto the primary camera of your smartphone. So once you have done that, you can just paste it with a micropore or a sellotape to the phone, and now you have a diffuse slit lamp right in your phone. You don't really require actually a slit lamp, but this is what is going to take anti-segment. You can put it in all type of phones and on your video mode and on the flashlight, and you'll be able to take images of the anti-segment very easily without a slit lamp. And this is a video of the same showing how to take this, and few images. Just because of want of time, I'll be going a little fast over here. So these are all the images taken from the ASP device, and this is the do-it-yourself thing, so anybody can do it. It's very easy with all the basic materials in your OPD. So this is also video which was taken from the ASP. The second innovation, so this is also in 3D printed. John sir was telling about the 3D printing technology. We use that to actually make an adapter. The next innovation is slit scope. So we thought, why not make another innovation and make it like a slit lamp. So we thought of making a slit torch. So basically we took a torch and we applied a small slit with the chart paper on top of a small sketch pen cylinder plastic, which was put together, and we were able to make a slit. So this is basically a slit that we did in the first prototype, and then we thought, why not make it more better, and with the 3D printer we started printing adapters of the same concept, and then it just within 350 rupees we were able to make this adapter which can be put onto the torch, and now you are able to take slit images with ASP and slit scope together, and nobody will recognize whether it is a slit lamp or not. So this is how easy it is, and it can be done by anybody with the things in your OPD itself. So next innovation is the ASP Gonio. Like I told you, ASP with the 10 diopter IOL, 8 diopter IOL or 6 diopter IOL, we can actually start taking Gonio images also of the angles. So these are the few images that we took without a slit lamp, just with ASP device, but with a diopter lens of 6 diopter, 8 diopter or 10 diopters. So these are all the quite good images that we got from the ASP Gonio. The next one is Scooby-Doo. So we thought, why leave cobalt filter? So we thought we'll do the ASPI device. We added one acrylic cobalt blue filter, and that will correspond to the flashlight, and the flashlight itself will get converted into a blue blue light, and now you get even cobalt blue imaging videography in your smartphone itself without a slit lamp. So we covered almost everything in the slit lamp. All the aspects of the slit lamp was covered with the smartphone. The next one was, why not do another technique where we can put the 30 diopter IOLs together. So we started sticking 4 30 diopter IOL one upon the other with Fevicol, again things which you get in the house itself. So you can just ask your kids or anybody to do this, they will help you. You don't have to do it by yourself, it's so easy. And then once you put this onto the phone, your phone is getting converted to a microscope. So once you've done that, you'll be able to see fungus, you'll be able to see, so you can see all the fungal hyphae, you can see a lot of hyphae over here, you can see caterpillar hair, you can see parasites, anything which you take from the slit lamp, you can put it and you can start taking images. So that is IOL scope. The next one is gimbal scope. Gimbal scope, basically using smartphone adapters, you are going to attach it to the retinoscope. So once you have attached it to the retinoscope, you will be able to take live images of the reflexes of retinoscopy with the reflex, against the reflex, again moment, and then even neutralization point, and it will become very easy for you to actually teach your mentees and your juniors. So this was gimbal scope. Next one was pupil mate. We actually made a VR headset which can actually, with the infrared LEDs that we get from the cameras of CCTV, and we actually made a pupil documenting device. You can see over here, the pupil over here, it gets recorded instantaneously live, and it becomes very easy. We use only the basic cardboard and old CCTV LED lights and camera to use it. So this was pupil mate, and then we have the trash to treasure red cam, basically making a red cam posterior segment imaging device using a sanitizer bottle. We'll make flaps over here so that it holds the 20D lens. And then the other side, you are going to put the smartphone and you will be able to take fundus images. And we made it more smaller by 3D printing, again the same technology. Over here you can see this was a keychain that I saw in one of the fair exhibition. So I bought it and I saw how this works. And we used this concept to actually shrink our red cam. And over here you can see how we have okay, over here you can see how the same keychain model we used to make the retina posterior segment imaging device. And so this is how we take images. Easily you can take videos also, and these are the videos that we took. I think the time is up. There are a few more innovations. I won't be able to cover this. Okay. So any other innovations I can actually show you later. Thank you.
Thank you, Dr. Prithvi. His innovations don't fit into a full session, let alone a 8-minute talk. So next we have Dr. Ankit Nair, who is going to talk to us about the 3D printed eye drop guide and the do-it-yourself eye drop guide which he developed during his post-graduation. Over to you, Dr. Ankit. So during post-graduation, you can do this.
Thank you. Good morning all. So I'll admit firsthand that glorifying eye drop guides isn't exactly what most of you gathered here might consider revolutionary or groundbreaking. But I have a case to make for a device, an often ignored device that can tackle how we, that can transform how we tackle adherence failures and wasted medications. We have all come across that elderly patient who lives in solitude and wondered if they can actually follow the regimen that we've prescribed to them. Curious, we asked them to demonstrate how they apply their eye drops. And we usually see one of these. It's either the anxious one, or the one who's not even close, the artificial tears, or the classic tip toucher. In fact, studies show that 6.8% of patients miss their eye, 28% contaminate the bottle tip, and only 3% patients show perfect drop installation technique. And the mean drops per installation was 1.8. So your eye drop bottle will most likely last half of what you'd expect it to. So it was another day during my residency when I came across this device when a pharma rep was giving away free samples. So there was this problem of self-administering eye drops, and it had apparently already been solved, and most of us didn't know about it. So was it a gimmick? If it worked, it should have also been a relevant therapeutic device, right? So imagine my surprise when I realized that it actually resolves the whole ordeal, the whole mini circus involving the frittering hands, the anxious blinking, and the eventual wet cheeks. And the process was as simple as 1, 2, and done. Turns out eye drop guides have been around for a while in a huge assortment of models specifically designed for unique purposes. There is apparently a perfect eye drop guide for everyone. If you have tremors or weak extremities, you have these squeeze assist models. If you're a one-night patient, you have these models with built-in mirrors attached. Or you just don't like the idea of something falling into your eyes. You have these models, these touch applicator models. So I ordered a bunch of them and tested them out on my peers. Some were a hit, others were not, and there wasn't a clear winning design. And I figured out why. It wasn't the design that mattered, but it was the size of the eye drop guide. Specifically, we have different size skulls, so it leads to different orbital shapes and sizes as well. So I took this issue to my mentor, Dr. John Davis, and you can probably guess where that landed me. So let's just look at how easy it is to make our own eye drop guides. No, you do not need to know any 3D product designing skills to get started, because there are websites like these Thingiverse or Printables that has a wide variety of design templates that you can download. So these are, the design is not our main concern here. You can have your pick, and also you can of course choose the color at the time of printing it. But before heading out, you want to take a ruler and roughly get your orbital margins measured. This will be the size of the base of the eye drop guide. The next size will of course be according to the eye drop bottle. So these are some models that I printed and again tested them out on my colleagues. And as you would expect, they were favored clearly over using just any random commercial eye drop guides. But as I say this, I realized that asking the elderly patient, which I mentioned earlier, to go print his own eye drop guide or order a 3,000 rupees one off Amazon is not a practical ask. So not to mention 3D printing isn't as mainstream a thing yet, maybe outside of engineering colleges. So in between all of this, I also came up with a DIY solution for easily applying your own eye drops. What you do is you go to any baby shop near you and you get yourself a silicone feeding bottle teat. It has to be silicone. Make sure it's not too compliant so that it doesn't collapse in case you put too much pressure on it, which you shouldn't need to do, by the way. Also, if they ask you what the age of the baby is, just say a random age. Don't say that you're not married yet, because it might be confusing. What you do now is you cut it out at the widest margin, and that's it. You have yourself a makeshift eye drop guide. Why this works? It already comes in different sizes according to the size of the age of the baby. It's made of silicone, so it melts into your eyelid creases and takes shape perfectly. So it's super comfortable on the skin. Also, since it's silicone, it can be sterilized by steaming, boiling, and it's even microwave safe. All the while, even the most premium ones costing you less than 100 rupees. The participants, in fact, remarked that it felt nicer to use than those 3D printed materials and the plastic commercial ones. By making this presentation, I'm hoping to encourage more of us to educate our patients, especially the alarmingly rising number of elderly, or anyone else for that matter, who wouldn't prefer to disturb their parents, their partners, or their children to help them apply eye drops, say, every 4 hours. Here's hoping for a future where everyone, young or old, apply their eye drops independently. Thank you.
So next we have Dr. Shishir. Dr. Shishir needs no introduction, so we're not even putting up an introduction slide. another prolific innovator, vitreoretinal surgeon. Many retina surgeons are innovators like this. I think it's more than others. Retina surgeons do a lot of these innovations. Over to you, Dr. Shishir.
Thank you, Dr. John, Dr. Biju, for having me in this session. So most of my innovations are in retina surgery, especially when I face some sort of a difficulty. So first innovation is this 3D printed glow port, which is a glowing vitrectomy trocar cannula, 3D printed with the help of Dr. Prithvi here. So we attached it onto a 25 gauge trocar cannula there, and then put it on both the for the vitrectomy port as well as for your light pipe, and then you charge it with your endo illuminator. So why this innovation? Because I was always finding it difficult to switch on and off the microscope light whenever I need to exchange my instrument. So then this, you don't need a microscope light source. You can just see where the cannula is already, and you can see that in the night, in the mesopic condition or in the nyctalopic condition, it kind of glows in the dark. So it's like an illuminated cannula, which I've been telling Alcon and other companies also to develop, but they've always been quite resistant towards it. So we got this 3D printed and using polylactic acid and a fluorescent material, and then you can using it for VR surgery can be easily sterilized and reused multiple times. So the second was subretinal BBG dye. So I was in redetachment cases, I was always finding it difficult to identify where the break is. Sometimes when the patient comes with redetachment, they won't have any PVR. I was always finding it difficult where the break is. So I thought instead of making retinotomies, why not let me try and find the source of the subretinal fluid or the source of the redetachment, which is could be a break somewhere in the periphery. So I decided to load the BBG dye into the subretinal injector there, and using a 41 gauge needle, I injected in redetachment cases, and then I steamroll the dye underneath the retina with the PFCL, and then you can see the source of the break when the dye comes out through the break over there. So this was subretinal BBG dye for identifying occult retinal breaks. Can be even be used in patients with albinotic fundus, where you won't know where the break is because of the pigmentation is not there in such patients, and then you can know where the break is by this dye getting steamrolled out through the break. So next was using TPA for PDR patients, never been described before. So TPA has always been used for submacular bleeds or submacular hemorrhages. So I got stuck in this one patient where with advanced diabetic eye disease, one-eyed. You can see that dense clot which has formed over the retina, which is detached, and it's very difficult to sometimes remove this clot. And then on top of that, if you go and put silicone oil, they're going to they're going to contract, and then they'll form membranes. So I got this idea, why not sort this clot issue out operatively itself. So that's when I decided just to use this TPA. I had TPA with me that time, and then I used it and use it through the cannula, injected TPA under air, and I waited for around 10 to 15 minutes. And you can see that whole clot, everything just got liquefied. And then it was extremely easy to remove. And then after removing this clot, located the source of the bleed, and then I cauterized it. So that's where TPA helped me in proliferative diabetic retinopathy vitrectomies. So this is post surgery. You can see that absolutely no clot even under silicone oil. So next was 27 gauge IV cannula drainage for subretinal fluid. So this again, I had difficulty in this one patient where there was this bullous detachment, and I was not able to induce posterior vitreous detachment. You can see how bullous the retina is there. Now everybody they talk about making a draining retinotomy. So I decided to make an external retinotomy, but not with your usual 26 gauge needle or not with the cut down technique. I decided to go for this 27 gauge IV cannula, where I inserted it into subretinal space, and then the cannula stays inside, and you can see the SRF being drained through those 27 gauge IV cannula. And if the SRF drains, then you can see the retina is completely attached, and even the silicone tip can stay inside without causing any iatrogenic break. So silicone tip stays inside and the fluid keeps coming out, and then you can do your other retinal maneuvers easily. So this can be used for choroidal drainages as well. So next is this small foreign bodies for forceps which we developed. We wanted a forceps with 44 millimeter length and a positive pressure. This forceps has a positive pressure and blunt tooth tips. So small foreign bodies, even magnetic or non-magnetic, can easily be removed with this small forceps. You can see the small tips and easily it can be removed. So we developed this with Epsilon So this was our fifth innovation. So these small things cases very challenging cases very easy. So that's the reason why I had these innovations here. So to conclude, so these are the few of the innovations: glow port, IV cannula, TPA we can use for PDR, occult brake with subretinal dye, and also these foreign body forceps. Thank you.
Thank you very much, all the speakers. We have maybe a minute left for discussion. Are there any questions for the speakers from the audience?
Biju?
Yes.
If you don't find the bleeder after TPA removal, will it bleed continuously? More bleed will be there, no? Sometimes, suppose, Shishir, suppose the oozing is at the disc. Okay, many times it happens. Oozing is at the disc. So you put TPA, remove this thing, but it will keep on bleeding where you cannot cauterize.
Yeah, so if the bleed is on the disc, you cannot cauterize, but otherwise you can cauterize.
Yeah, most of the times, then will that result will be profuse bleeding under the oil after surgery? No. Disc bleed, you cannot cauterize, no?
No, that's what I said. After removing the TPA, you have to cauterize the bleeder. That is the primary source of the bleed.
But if it is at the disc, you can't do.
Yeah, if you are at the disc, then you cannot.
Probably better not to put TPA if you suspect bleed.
No, TPA will liquefy the whole, this huge large clot. I cannot proceed with surgery.
Actually, clot is needed to stop the bleed.
Yeah,
at the disc. At the disc.
At the disc, yes.
So, if it is at the disc, better not to put TPA.
Put TPA, yes.
Yeah.
I think if there are no more questions, we will close the session. And thank you, speakers. We did a good thing on stopping on time, ready for the next talk. Yeah, thank you. Thank you very much.
Thank you, sir.